Hello, I am Geraldo Rodriguez Diez. I am an EP from Mexico City, and my task today is to talk about cryoballoon ablation guided by ice. I would like to thank you, Dr. Luis Carlos Sainz, President of LAHRS, for this invitation. And I will start mentioning the advantages of ice, because we could watch all the procedure in real time. That's why we could detect thrombus or other complications, identify vagal reactions from pericardial effusion, mainly if there is suddenly drop of the heartbeat. We could also earn fluoroscopy, earn a contrast medium, and enter into the structure that we want to enter. Finally, we could optimize the vein occlusion guided by color Doppler. When I perform cryoballoon ablation, I always wanted to use ice. That's why I will show you step by step how do I perform this procedure. First of all, we need to rule out the presence of thrombi. And with ice, we could avoid intraesophageal echo prior to the procedure, and also we could avoid tomography. Because with ice, we could watch the pulmonary veins, we could watch the left atrium, we could watch the left atrial appendage. How we start? We start with the classic home view. The home view is the view that we could see the tricuspid valve. Then, when we see the tricuspid valve, we flex the eyes and push it in order to enter the right ventricle. Then we turn the eyes clockwise until we observe the left ventricle, then the aortic valve. In the aortic valve will be on top, the left atrial appendage in the middle, and on the bottom, the left superior pulmonary vein. This is the classic home view when we could see the tricuspid valve. Then we flex the eyes, push it, and enter into the right ventricle. Then we turn the eyes clockwise, watch the left ventricle, and then watch the aortic valve. Here's the aortic valve. In this projection, we could watch the aortic valve on top, the left atrial appendage in the middle, and the left superior pulmonary vein on the bottom, under the left atrial appendage. This projection is also useful when we enter continuously in the left atrial appendage. We don't need to do that because we could perforate the atrial appendage. When it happens, we need to pull out the sheet, then turn clockwise and enter into the left superior pulmonary vein. There is another view in the right atrium, watching the mitral valve, that allows us to watch the left atrial appendage and rule out the presence of thrombus. So the next step is that once we rule out the thrombi, pull back the sheet, and we will drop in the right atrium. This spot is the perfect to perform the transeptal puncture. The optimal site is when we see the left pulmonary veins across the septum. Sometimes this space is very narrow and it's very hard to perform the ablation. And it's very important that once we crosses to the left atrium, we look out the presence of thrombus on the sheet. This is the view where we have the left pulmonary vein across the septum. So we push with the needle and the sheet, push firmly but not too hard, and then cross to the other side. When we cross, we inject water to make bubbles and to verify that we are in the left atrium. Like I said before, sometimes the space is very narrow, mainly when there is aortic root dilatation, for example, in patients with Marfan syndrome. Could be very hard to cross the other side. Also, if we have a aneurysmatic septum, could be hard to cross to the left atrium. And when we cross, we need to look out if there is any thrombus in the sheet. Like in this example, there is a thrombus stuck in the sheet, or could be stuck in the weir. So when it happens, we need to inject heparin and wait till the thrombus disappear. If we need to exchange the sheet, we could use this projection, always watching the wire, and then pull back the sheet, make the exchange with the flex cat, and then put it again. Once we have the flex cat in the left atrium, we can start to perform the pulmonary vein isolation. The goal of the therapy is to a complete occlusion of the pulmonary vein. And we could verify this occlusion using contrast medium with fluoroscopy or color Doppler with eyes. And we can also use the eyes to navigate with the achieved catheter to enter or cannulate the pulmonary veins. In here we have the balloon inflated and we are occluding the pulmonary vein, the left superior pulmonary vein. And with color Doppler, we verify that there is no leak of blood, and this is a complete occlusion of the pulmonary vein. In this projection, we have the total occlusion of the left superior pulmonary vein and the flow of the left inferior pulmonary vein. But the target in here is the left superior pulmonary vein. This is a correct place to start the therapy and may perform the pulmonary vein isolation. We verify in the borders of the balloon that there is no leak. We could navigate with the achieved catheter to cannulate the pulmonary vein. This is the flow of the left inferior pulmonary vein. There is the achieved navigating into the pulmonary vein, and here is the balloon inflated in a correct way to perform the PVI. This projection, we could see the occlusion of the left inferior pulmonary vein and the flow of the left superior pulmonary vein. When we are done with the left structure, we need to go to the right structure. The right pulmonary veins are technically more difficult from the left. We need to pace in the diaphragm to avoid phrenic palsy. This is the balloon inflated in the right superior pulmonary vein. Here's the chief navigating to cannulate the right inferior pulmonary vein, and here is the projection, the right atrium, and the cryoballoon is very close to the septum, and it's occluding the right inferior pulmonary vein, and we have the left atrium. We corroborate the adequate occlusion with color Doppler, and we could see in here the flow of the right superior pulmonary vein, but a complete occlusion in the right inferior pulmonary vein. Finally, we check all again. Once we are done with all the pulmonary veins isolation, and we return to the home view. Return to the home view, enter into the ventricles, rule out pericardial effusion or cardiac tamponade, then turn clockwise, see the aortic valve, watch the left atrium, and then if there is rule out the presence of thrombi, we could move forward and perform another procedure in the patient. Another procedure like cryoballoon ablation of the left atrial appendage, or place an occluder device, or ablation of the cavotricuspid isthmus due to typical flutter. This is the projection of the left ventricle, and in this example, there is cardiac tamponade. Sometimes could be mild pericardial effusion because the edema for the ablation, but is different to the cardiac tamponade, like this example. We always, after the procedure, have this image, is edema in the ridge of the appendage, the structure that divides left atrium from the left superior pulmonary vein. If we need to put an occluder device, we need to perform the measures before the cryoballoon ablation, and then perform the ablation and put the occluder. This is an example of a cryoballoon ablation of the left atrial appendage, and this is an example of occluder. This is amulet guided by ice. Just after the cryoballoon ablation. If we need to perform ablation of the typical flutter, this is a projection with the cavotricuspid isthmus. We perform the ablation with this view. In conclusion, ice could make more comfortable the cryoballoon ablation procedure because could identify complications like thrombi or pericardial effusion, could avoid some fluoroscopy or contrast medium, make more efficient the pulmonary vein occlusion, and allow us to perform other procedures such as cryoballoon ablation of the appendage or put mechanical devices. This is the final image. It's comparing the amphibious ajolote. Axolot is a danger species from the Xochimilco Lake in Mexico City. It's a complex amphibious, and so is the left atrium. It's a very complex cavity. That's why it's very difficult to treat atrial fibrillation. Thank you very much.